oxygen supply, our our body cells will tend to utilize glucose by anaerobic metabolism. The end product would be lactate. Okay, and this lactate will contribute to the acidosis which occurs in shock. And then there'll be further depletion of glucose due to the utilization, and this will lead to at one point of time there'll be no ATP generation. Even anaerobic metabolism doesn't occur, and there is no ATP generation. At this point of time, the sodium potassium ATPase pump will stop working. So when this stops working, there will be increased sodium and fluid influx into the cell, leading to cellular swelling and cell death finally. Okay, and further there will be calcium influx into the cell. This will lead to activation of phospholipases and other enzymes, leading to autodigestion of the cell. So this is the pathophysiology at the cellular level, what happens in shock. Further, the release of all these intracellular contents will lead to activation of the inflammatory cascade, causing inflammation. So, we before going to the classification of shock, we should see what are the determinants of shock, determinants of oxygen delivery. Okay, so what for oxygen delivery, there are two main components, which is cardiac output and arterial oxygen content. Okay, so the two components of cardiac output would be heart rate and stroke volume. Okay, so any changes in the heart rate or the stroke volume, you can manifest as shock. And further, oxygen carrying capacity of the blood depends upon the hemoglobin levels. Okay, so these are all the determinants of oxygen delivery. Coming to classification of shock, shock is classified into four types: distributive, cardiogenic, hypovolemic, and obstructive shock. Okay, so coming to the first type of shock. Next slide, please. I'll come to this table later. Go to the next slide. So, distributive shock. Distributive shock, the primary disturbance is reduced systemic vascular resistance. That is, the peripheries, there will be vasodilation in the peripheral vessels. Okay, that is reduced systemic vascular resistance. So, to compensate for this, there will be an increase in the cardiac output. Okay, so the most common cause for distributive shock is sepsis. Other causes are pancreatitis, liver failure, anaphylaxis, neurogenic, endocrine, and adrenal crisis. In in brain and spinal cord injury, there is neurogenic shock. There is disruption of the autonomic pathway, leading to pooling of blood in the veins, which will decrease the cardiac output, leading to shock. Okay, this is all the causes of the various types of shock is given in the table. Okay, which we saw previously. You can see the causes for distributive shock: septic shock, pancreatitis, severe burns, anaphylactic shock, neurogenic shock, endocrine shock, and adrenal crisis, which I have mentioned in the slide. Okay, coming to cardiogenic shock. So, in cardiogenic shock, shock occurs mainly due to cardiac cause. Okay, so there's a problem in the cardiovascular system which leads to a shock. So, the stroke volume may be reduced due to decreased contractility of the heart, mechanical valvular disease, or due to bradyotachyarrhythmias. So, how to identify? Like, if when the cardiac process affects the left ventricle, there will be an elevated pulmonary capillary wedge pressure. And when the cardiac process affects the right ventricle, there will be an elevated central venous pressure, elevated JVP, which you can see. And for cardiogenic shock, there will be a compensatory increase in systemic vascular resistance. Whereas in distributive shock, you'll have a decreased systemic vascular resistance. Okay, so the common causes of a cardiogenic shock would be your MI, acute MI, myocarditis, arrhythmias, or valvular heart disease. Okay, mostly the regurgitant heart disease, aortic valve, aortic regurgitation, mitral regurgitation. Okay, next coming to obstructive shock. Next slide, please. Hypovolemic shock. Hypovolemic shock Previous slide. So there is decreased cardiac output due to reduction in preload. So the common causes of hypovolemic shock are diarrhea and vomiting. Okay, burns, severe burns. In severe burns, there'll be fluid loss. Okay, or any hemorrhage in road traffic accidents, both internal as well as external hemorrhage, and renal loss, as seen in diabetes insipidus. So the features would be a compensatory increase in systemic vascular resistance and a low central venous pressure. Okay, coming to the next one, type, obstructive shock. Here there is a decreased cardiac output due to an extracardiac process impairing the outflow of blood. So the decreased venous return to the heart will occur in case of tension pneumothorax, cardiac tamponade, and restrictive pericarditis. In tension pneumothorax, there will be a positive pressure which will prevent venous return to the heart. Okay, and decreased outflow from the heart will occur in pulmonary embolism. There will be decreased outflow from right heart and aortic dissection. Okay. So next would be the stages of shock. Next slide, please. Yeah, compensated, uncompensated, and irreversible. So during the initial stages of shock, our body will try to compensate for what is happening, and so the symptoms will be minimal, and even lab investigations will not show much changes. Okay, so that is compensated shock. Please go to the next slide. So here the physiological responses will occur to counteract the initial insult. There is no end organ damage, and lab investigations will show a mild increase in lactate and creatinine. Next, coming to uncompensated or decompensated shock. Here the compensatory mechanisms are overwhelmed and symptoms of end organ damage will start to manifest. So initially there will be no symptoms, but in uncompensated shock, when there is decreased blood flow to all organs, preferentially the body will try to increase the blood flow to the brain, okay, to the kidneys. And so when a person starts manifesting with CNS symptoms, it means that the compensation has been overwhelmed. So in the patient presents with altered sensorium, decreased urine output, it means that they've reached the maximum compensation, organ dysfunction has started occurring, and we can still restore perfusion with appropriate intervention. Next, coming to irreversible shock. In this stage, there is permanent organ dysfunction. Patient will progress to multi-organ dysfunction, and the mortality rate will be very high. Okay. So, how to evaluate a patient with shock? So, the key principles in treatment of shock would be to recognize the shock early, to assess the type of shock present, initiate therapy simultaneous with evaluation into etiology of shock. And then restoration of oxygen delivery is the aim of therapy. Identify etiologies of shock additional to the life-saving interventions. Okay, so first we have to start from history taking. This will help in identifying the type of shock. For example, in septic shock, patient will have an evidence history of fever, history of any ulcers, okay, a diabetic foot, or any infection, pneumonia. He may have an breathlessness or fever. Mainly, they'll come with complaints of fever. Okay, whereas in hypovolemic shock, you can expect a history of diarrhea, vomiting, or any trauma. Okay, so history can help in identifying the type of shock and early initiation of specific treatment. Okay, in anaphylactic shock, there will be a sudden history of collapse following exposure to an allergen. Okay, so coming to the examination, the aim of examination is to identify if shock is present or not. Okay, to identify the type of shock, and also whether organ dysfunction is present. Okay, so what we'll be seeing in the physical examination is vitals. We have to check the heart rate, respiratory rate, BP. Okay, BP usually will be low. And due to decreased oxygen, cellular hypoxia, and acidosis, patient will have tachypnea. Okay, and then we can also calculate the shock index with the help of heart rate and BP. Normal shock index is zero point 0.5 to zero point 0.7. If it's elevated more than zero point 0.9, it indicates it's an indicator for transfusion requirement. Okay. Next, we after vitals examination, specifically for cardiovascular system, we can look into the JVP. If JVP is elevated, it indicates right heart failure. Okay, elevated JVP, pedal edema, all indicates right heart failure. We can assess the patient's mental status, whether he is having any altered sensorium, which indicates that patient is having, his CNS system is affected, and patient will have a delayed capillary refill time of more than 2 seconds, which you can assess by you can just place your finger over the toe, the plantar aspect of the patient's toe, and then release it and check for the capillary refill. Then oliguria, you can catheterize the patient and check if the patient is having decreased urine output of less than 0.5 ml per kg per hour. That indicates oliguria. So these are all the general examination findings which you're going to see in a shock patient. Okay, and specific for in obstructive shock, in case of tension pneumothorax, you'll be having a silent chest. Okay, which will be hyperresonant on percussion. Or examination, if there is any abscess or carbuncle, furuncle, or any ulcers, you can also, if you find that, it could be a clue to septic shock. Okay, so Q-SOFA score. Coming to Q-SOFA score, this helps in predicting the mortality. Okay, so this is a quick sequential organ failure assessment score. 1 point is given for BP, respiratory rate, and altered mental status. BP less than 100, respiratory rate more than 22, and altered mental status, that is GCS, less than 15. So Q-SOFA score more than or equal to 2 will indicate an increased risk for death or prolonged ICU stay. Okay. So next, coming to the diagnosis. So lab investigations, routine investigations we have to do for a shock patient is a complete blood count. In uh, sepsis, we can see an elevated total count, thrombocytopenia. Okay, and he- hypovolemic or hemorrhagic shock they'll definitely acute loss of blood. There'll not be much change in hemoglobin, but there can be. Coming to RFT and LFT, a derangement will indicate multi-organ dysfunction. Okay, ABG to look for acidosis. Then serum lactate levels may be elevated in, as I said earlier, because of anaerobic metabolism. Okay, cultures. We'll have to take blood culture and urine culture. Hello, am I audible?
Yes, ma'am.
Yes, ma'am, you're audible.
Yeah. Blood cultures and urine cultures to look for sepsis, and then cardiac enzymes to CKMB. Okay, troponins for MI, and then an ECG and echo. So in the ECG, you can see if there's an if there's an ST elevation, it could be probably a cardiogenic shock. Okay, and in pulmonary embolism, ECG, you can see S1Q3T3 pattern or sinus tachycardia. Okay, uh, echo findings. Echo can be used to find out the contractility. Okay, the ejection fraction of the heart. So when there's a decreased ejection fraction, uh, it might be due to cardiogenic cause. The shock may be due to cardiogenic cause. Echo can also identify a large proximal thrombus. Okay, pulmonary thromboembolism can also be identified. So these are the uses of echo. Next, coming to initial treatment. So first, when a patient comes with shock, first is to gain a large bore IV access. Okay, and a central venous catheter would be better because this can be used for both IV fluid infusions as well as for monitoring. Okay, monitoring of the central venous pressure, we can use it. Then we are going to give volume resuscitation, okay, to restore the tissue perfusion. Initially, we'll give crystalloids for any type of shock. Even in cardiogenic shock, we can give guarded volume. Initially, we can give fluids based on after echo and all we can give. Okay, so crystalloids 30 ml per kg in suspected septic shock. And for hypovolemic shock, we are going to give crystalloids, blood, and blood products. So initially, we'll have to find an IV access, okay, and start hydrating the patient. Next, coming to the specific treatment. So after we'll have to assess the intravascular volume after we give IV fluids. Okay, so for assessing the intravascular volume, you can use a passive leg raise test. Okay, we can also check for IVC diameter and we can use pulmonary artery catheter. So the passive leg raise test is to predict the responsiveness to the IV fluids we have given. Okay, in this we'll have to raise the legs to 45-degree angle and then measure the change in cardiac output, which can be measured as a change in pulse pressure. So more than 12% variation will suggest volume responsive state. Okay, the other methods would be the placement of pulmonary artery catheter and IVC diameter and IVC collapse, which can be identified in USG. Okay. Next, coming to inotropes and vasopressors. Okay. So, if intravascular volume status has been optimized with volume resuscitation, but hypotension and inadequate tissue perfusion persist, then inotrope support should be initiated. For distributive shock, our aim there is a decreased systemic vascular resistance. So, our aim will be to increase the systemic vascular resistance. So, the first choice will be noradrenaline, which is an alpha 1 and beta 1 agonist. Okay, so alpha 1 will cause vasoconstriction, beta 1 has a positive inotropic effect and chronotropic effect, increases the force of contraction and the heart rate. Okay, so in distributive shock, vasopressin can also be used because there might be a vasopressin deficiency, can be used along with NORAD as a second line. Okay, dopamine is not does not have a role as a first line agent in distributive shock. Okay, coming to cardiogenic shock, we can use dobutamine. Dobutamine has primarily beta effects with the minimal alpha effects. Okay, beta 1 will increase the inotropy, beta 2 causes vasodilation with decreased afterload. Okay, so when the afterload decreases, the pumping efficacy will increase, but we should not we should provided the heart, SBP is a little bit at the higher end, we have to give dobutamine and monitor the BP at regular intervals. Okay, then coming to oxygenation and ventilation, in addition to cellular hypoxia, patient will also have hypoxemia. So for all types of shock, they can be a development of ARDS and subsequent VQ mismatch and shunt. So we have to provide supplemental oxygen. Mechanical ventilation may be required. Okay. Uh, then finally, the specific causes of shock requiring tailored intervention. So for sepsis, we are going to initiate patient on antibiotics. Okay. For anaphylactic shock, we are going to remove the allergen and administer epinephrine. Okay, and IV fluids and vasopressors. Adrenal insufficiency will require IV steroids. For tension pneumothorax, you'll have to immediately decompress it with an ICD. Okay, proximal pulmonary embolism may require thrombolysis, and aortic dissection requires surgical intervention. Okay, so that's it. This is a small topic. There is you can read about each type of shock, mainly septic shock. Okay.
Thank you, ma'am.
Yeah, thank you.
Thank you, ma'am.